Thank you for attending the grand round of our ward in pulmonology, despite a lot of work which you may have had to do. Today we are presenting, I'm doing a case presentation of a 24-year-old male who resides in Salama Road, Yoruba tribe, conductor, Protestant, other issues. You can see them there. He was admitted on 11th of July 2018. He came with presenting complaints of left-sided chest pain for a period of 2 weeks and difficulty in breathing for 2 weeks. In the history of presenting complaint, he was well until 2 weeks prior to his admission, when he developed a dull constant left-sided chest pain, worsened by movement and breathing, and it was relieved by paracetamol. The pain was non-radiating. It was associated with a difficulty in breathing that was worse on exertion. He had been managed with the unspecified antibiotics in the community without much improvement. However, he had no wheezing, no cough, no hemoptysis, no orthopnea, no paroxysmal nocturnal dyspnea, or lower limb swelling. He had a high-grade intermittent fever. The weight loss was very minimal and no drenching night sweats. The review of his system, the GIT had occasional burning and epigastric pain radiating to the gastrointestinal area, worsened by meals and relieved by antacids. No other GI symptom. Other systems were unremarkable. In the past medical history, this was his third admission. His first admission was a year ago for surgery, where he was operated for pancreatic pseudocyst. The second admission was 6 months ago, due to gastritis and an exacerbation. He had an exacerbation of gastritis that was managed with PPIs, and the symptoms resolved. He's HIV negative, has no other chronic illness that is known, or drug or food allergies. The past surgical history was operated for pancreatic pseudocyst early in 2017, and this was attributed to alcoholic pancreatitis. He received 1 unit of blood transfusion during that time. He's a firstborn in a family and social history. He's the firstborn of 3 children in their family. He's single, his father died. He used to take alcohol regularly until he fell sick. And even before his father died, also asked him, he used also to take some. He studied up to P5, but he has no history of tuberculosis. So in summary, I'm presenting a 25-year-old HIV cell negative male with history of chronic pancreatitis and excessive alcohol ingestion, who presented with a 2-week history of fever and chest pain associated with night sweats. However, there is minimal to negligible weight loss. He also reported recurrent epigastric pain. In our differentials, we had a pulmonary TB, atypical pneumonia, community-acquired lymphomal gastritis. Physical examination, he looked unwell, he was moderately wasted, he had mild pallor, the mucous membrane was febrile, temperature 37.8, he had grade 3 finger cramping, but no lymphadenopathy, no cyanosis, all peripheral edema. The vital signs, the BP 110/70, heart rate 110, oxygen saturation 96, room air, and he had a 24 pace, respiratory rate of 24 breaths per minute. The respiratory system, he had mild respiratory distress, tachypneic. The trachea was deviated to the right with reduced chest expansion on the left side, stony dull percussion note on the left thorax, and absent breath found on the left hemithorax, and the right hemithorax had normal findings. The cardiovascular system, there was a tachycardia, there was a pulse, full volume pulse, regular, normal JP, normal precordium. The first and third sounds were heard, but they are muffled. The apex beat was not displaced. The CNS was fully oriented with a Glasgow Coma scale of 15/15, and the pupils were equal and bilaterally acting to right, and there were no focal neurological deficits. Abdomen, he had moderate distension symmetrically with mild epigastric tenderness, no guarding. Hepatomegaly was just 4 centimeters below the costal margin. There is no splenomegaly, no shifting arteries. Impression, we said this is a left-sided perfusion. It's a paramnemonic fusion of TB, or sepsis, with a septic foci from the chest, and chronic alcoholic with having chronic liver disease and alcohol-induced gastritis. So investigations on arrival, the complete blood count was done. The leukocytosis of 10.57, that is 10,570. Neutrophil predominating 77%. Mild anemia of 12.5. ADM CV is also low, with a thrombocytosis of 640/42. So that was the chest X-ray. I tried to image it using some techniques, but I went to the neurology, but I could not get it originally in the computers. So I had to use, but basically it is showing obliteration of the left lung field. You can't see anything there. And the right lung, you can see some tissue there. So other investigation, the pleural aspirate was done. I aspirated the purulent material. The liver function and the renal function tests were essentially normal. HIV is negative. The sputum for inexpert was also negative. The abdominal chest ultrasound, they noted the left-sided massive perfusion with hepatomegaly, the full, I think they gave a full span of 17.1 centimeters. This is ultrasound. But there are no nodules or any masses. The spin was reported to be normal. The pleural fluid analysis was purulent with a WBC count of 5,300, protein 4,000 milligrams per deciliter, neutrophil 80%, gram stain the numerous past cells, and the ZN stain the acid fast bacilli. The culture of the pleural fluid is still pending for aerobic and anaerobic organisms, and the fungal cultures were not there. So in summary, it is an exudative, it is an exudate actually, with a neutrophil predominant. Tentatively, the patient was diagnosed actually, it was the diagnosis of Empyema thoracis was actually made in a chronic alcoholic, and they started him on IV ceftriaxone and metronidazole, paracetamol in the doses you can see there, and advised him to drink and take some fruits orally. Therapeutic thoracentesis was also done, and they removed 2 liters of fluid. In the follow-up for pleural fluid cytology, it was negative for malignancy, and the peripheral blood smear was done to see the cause of the thrombocytosis. But there were no other hematological abnormalities with the exception of thrombocytosis. So despite the treatment I've just mentioned, the patient continued to have fevers, and what I didn't say, the chest tube was inserted and drainage was going on. While on drainage, that was the evolution. You can see now on the right, you can see some lung tissue now compared to the previous one. And culture and sensitivity of pleural fluid revealed the gram-negative rods sensitive to meropenem, which was initiated at 1 gram 3 times per day. Fever subsided and the patient improved. Currently, the patient is in the ward, feeding well, and no more fevers. Thank you.